labor. Next slide, please. So this stage of labor comprises a phase of placental separation, its descent to the lower segment, and finally its expulsion with membranes. Next slide. So what happens? At the beginning of labor, the placental attachment roughly corresponds to an area of 20 centimeter in diameter. Now, as labor progresses, there is no appreciable diminution of the surface area during the first stage. Now, once you have entered the second stage, there is slight but progressive diminution of the area following successive retraction, which attains its peak immediately following birth of the baby. Next slide. So after the birth of the baby, the uterus measures about 20 centimeter vertically, 10 centimeter anteroposteriorly, and the shape becomes discoid. The wall of the upper segment is much thickened, while thin and flabby lower segment is thrown into folds. The cavity is much reduced to accommodate only after birth. Next. Marked retraction reduces effectively the surface area at the placental site to about its half. But as the placenta is inelastic, it cannot keep pace with such an extent of diminution, resulting in its buckling. So what happens? A shearing force is instituted between the placenta and the placental side, which brings about its ultimate separation. The plane of separation runs through deep spongy layer of decidua basilis, so that variable thickness of decidua covers the maternal surface of the separated placenta. Next slide, please. Now there are two methods of placental separation. Next. Here you can see this. What happens? There is central separation. This is known as Schultz method of placental separation. What happens? There is formation of a retroplacental hematoma, which goes on increasing in size, and this causes detachment of placenta from the uterine attachment, and with increasing contraction, more and more detachment occurs, facilitated by weight of the placenta and retroplacental blood, until whole of the placenta gets detached. Next. Now, marginal separation. This is also known as Matthew Duncan way of separation of placenta. Here, the separation starts at the margin, as it is mostly unsupported. With progressive uterine contraction, more and more areas of the placenta, they get separated. So, but marginal separation is found more frequently, that it is more common than Schultz method. Next. Now, separation of the membranes. The membranes which are attached loosely in the active part are thrown into multiple folds. Those attached to the lower segment are already separated during its stretching. The separation is facilitated partly by uterine contraction and mostly by weight of the placenta as it descends down from the active parts. The membranes so separated carry with them remnants of decidua vera, giving the outer surface of the chorion its characteristic roughness. Next. Now, after complete separation of the placenta is forced into the flabby lower uterine segment or upper part of the vagina by effective contraction and retraction of the uterus. Thereafter, it is expelled out either by voluntary contraction of abdominal muscles or by the manual procedure. Next. Now, after placental separation, innumerable torn sinuses, which have free circulation of blood from uterine and ovarian vessels, they have to be obliterated to stop the bleeding. The occlusion is affected by complete retraction, whereby the arterioles, as they pass tortuously through the interlacing intermediate layer of the myometrium, are literally clamped, is the principal mechanism of hemostasis. However, thrombosis occurs to occlude the torn sinuses, a phenomenon which facilitated by hypercoagulable state of pregnancy. Apposition of the walls of the uterus following expulsion of the placenta also contributes to minimize blood loss. Next slide, please. So here you can see the arteriole is passing through the crisscross muscle fibers. And when the muscle retracts, what happens? This arteriole is also trapped and it also contracts, and thus bleeding is stopped. Next. So, third stage includes separation and expulsion of the placenta with its membrane. And what happens? There may be pain. For a short time, the patient experiences no pain. However, intermittent discomfort in the lower abdomen reappears corresponding with the uterine contraction. And before separation, per abdomen uterus becomes discoid in shape, firm in feel, and non-ballotable. Fundal height reaches slightly below the umbilicus, and there may be slight trickling of blood. The length of the umbilical cord, as visible from outside, it remains static. Next. Now, it takes about 5 minutes in conventional management for the placenta to separate. So, when you feel per abdomen, the uterus is globular, hard, and ballotable. The fundal height is slightly raised as the separated placenta comes down in the lower segment and the contracted uterus rests on the top of it. Slight bulging in the suprapubic region due to distension of the lower segment by the separated placenta occurs. Next. Now, once the placenta separates, what happens? This is followed by a gush of vaginal bleeding. There is lengthening of the cord, and this can be elicited by pushing down the fundus when a length of cord comes outside the vulva, which remains permanent even after the pressure is released. Alternatively, on suprapubic pressure upwards by the fingers, there is no indrawing of the cord, and the same lies unchanged outside the vulva. Next slide. So now, this is the third stage of labor where complications are likely to occur. So it has been seen that with active management of labor, where you do not use any medication, there is more bleeding, more postpartum hemorrhage than when you use these uterotonics. So now WHO has recommended active management of third stage of labor. Next slide, please. So we all know that the first stage is true labor pain to full cervical dilatation. Second stage is full cervical dilatation to delivery of the fetus. Third stage is delivery of the fetus to expulsion of the placenta. And the fourth stage is expulsion of the placenta to 2-hour observation of both mother and the baby. Okay. So next slide. So we do active management of third stage of labor for all deliveries. And what are the steps? This is administration of a uterotonic drug, then controlled contraction and uterine massage. Next. So before giving uterotonic, you have to exclude another fetus Then administer within 1 minute of delivery of the baby. But you should know what will be the drug, what will be the dose, what will be the route, and how do you store it. Okay. So next slide, please. Oxytocin. In 10 unit intramuscular, it should be stored in fridge at 2 to 8 degrees centigrade temperature or at room temperature less than 25 degrees centigrade. So cold chain has to be maintained from production to transportation to storage and to administration. So this cold chain should not be broken at any one point. Next. Next comes carbetocin. This is heat stable. You can give 100 microgram intramuscular or IV. It is stable at room temperature. Next. Next slide, please. You can also use oral misoprostol. Government of India has used misoprostol 400 to 600 microgram for rural women where there is lack of electricity. So you give it orally. Next. Next slide, please. So what are the recommendations for active management of third stage of labor? So where there are no trained staff, misoprostol is the drug of choice, 400 to 600 microgram by trained community health workers and lay health workers. Is cold chain transport and storage available? If no, you should give carbetocin, which is heat stable, 100 microgram IM or IV. But since it is more costly, you have to see whether your community, whether your patients are able to take it, whether it is cost effective or not. The other option that we have is misoprostol 400 microgram or 600 microgram per orally. Now, is oxytocin available? If not, you can give carbetocin, you can give misoprostol, you can give ergometrin, but ergometrin should not be given in hypertensive disorders and it can be safely excluded prior to use. Or fixed dose combination of oxytocin and ergometrin in contexts where hypertensive disorders can be safely excluded prior to use. Oxytocin 10 international unit IV or IM. Next. This we have already discussed. What are the signs of placental separation? As the placenta separates, there are the open sinuses from which blood comes out in a gush. Then there's lengthening of the cord, which is permanent, and the uterus becomes firm and globular and hard, like a cricket ball. Next. Now, the second part is you have to do controlled contraction. First, you have to be sure that the placenta is separated. Then you give traction during contraction, but skilled birth attendant must be present. Next. Once the placenta comes out, what you have to see? You have to see for the cord, you have to see for the membrane, and you have to see for the placental cotyledons. Whether any cotyledon, this is the maternal surface, and you have to see whether any lobe of placenta is missing. Or for the umbilical artery, you can see whether it is one artery or two artery. Next. Now, instead of uterine massage, now WHO and FIGO say that you should assess the uterine tone. Next. So, skilled health workers lead to a 54% reduction in mortality at birth. Next.